Anyway, last but hardly least, a presentation from a young faculty member trained mostly in the UK, now joining us in the departments of interventional radiology, adult and pediatric, to talk about islet cell transplantation. Avnesh.
Thanks a lot. So I know that I'm between you guys and lunch, so just bear with me for a little bit longer. I'm actually going to talk to you a little bit more about interventional regenerative medicine, which is an area which my lab is really focusing on, and leave the islet transplantation for another date at present. So I'm just going to start off a little bit about looking at pancreatic anatomy. So it's an interesting organ which lies very deep within the retroperitoneum. It's about 6 to 10 inches long, and we kind of characterize it into 3 main sections, which is the body, tail, and head. But the interesting factor about this organ is that it has both endocrine and exocrine components. So if we look at the endocrine component, oops, a little bit too fast, it's really consisting of islets, and the islets really compose only between 2 and 5% of the gland itself. And the endocrine component releases a variety of hormones within the bloodstream, which actually then are able to regulate metabolic indices, and the main one would be glucose that we'll look into. The majority of the gland, 95 to 98%, is the exocrine components, and they release enzymes for digestion of various stuff that we eat in our guts. So what is insulin? So, well, insulin is secreted by the beta cells. It's a 51 amino acid dimer, and it actually promotes the absorption of glucose from the blood. And so when we get diabetes, we have a dysregulation in this, and we have type 1 diabetes, which is where the beta cells which secrete insulin are destroyed. And we have type 2 diabetes, where blood glucose levels rise as a result of end-organ resistance. Now, if we focus on type 1 diabetes, that is a result of an autoimmune response. And what happens here is that there's a dysregulation now in the way the immune system is actually monitoring and policing the pancreas. So what actually happens is that the T effector cells, which actually look at antigens on the beta cells, start to proliferate, and they lose their regulation by the T regulatory cells. And as a result of this, what actually starts to happen is the beta cells start to get destroyed, and that results in lack of insulin being produced, which results in glucose levels rising. So if we look at this, we see that as the disease progresses, we start to get a reduction in beta cell mass. And when we get about an 80% reduction in beta cell mass, we clinically start to develop symptoms. So when 20% of the islets are remaining, patients start to exhibit symptoms of hypoglycemia. So we then started to kind of characterize this in terms of where does the research fit in relation to how the gland is actually being destroyed by the autoimmune components. So when we have enough beta cells still remaining, so that's before the kind of the 20% hit off, there's probably a window there when we can actually start to regenerate the pancreas. After that, once we start to get very symptomatic and there's a limited number of islets remaining, we're kind of looking more into the islet transplantation space. And then don't forget that we always have to have some form of immunoregulatory control, and that's where another avenue of research is actually taking place, because no matter what we regenerate, if we regenerate it, it's just going to be destroyed again. So my lab really focuses on the bottom two. I kind of leave the immunotherapy to more intelligent people than myself. So I look at pancreatic regeneration and islet transplantation. And for this talk in particular, I'm going to focus a little bit on pancreatic regeneration. So if we think about how we want to regulate or regenerate the pancreas, we kind of can divide it into 3 main areas. One, how do we get to the organ? Okay, so that's a major problem because of its location within the abdominal cavity. So one area where we're focusing on is, can we get to this organ via its arterial blood supply? The second question would be, if we can get to the organ, what can we give to the organ to try and re-stimulate and regenerate the beta cells that are being destroyed? And then are there any adjunctive technologies which will then facilitate all these different types of approaches such that we can get an improved response over conventional-based approaches? So I'm going to take you through each one of these very quickly. So if we look at the delivery aspect of things, can we access the arterial blood supply of the pancreas? Well, I've just told you that the pancreas is in a horrible location for kind of direct access. What makes it even more complex is the arterial blood supply is even more complicated. So unlike other solid organs, like the liver and the kidney, for example, which have a dedicated arterial blood supply, the pancreas doesn't. And its blood supply really looks like this, which is a very complex anastomotic arcade of multiple small vessels that supply this gland, really originating from the celiac axis and the superior mesenteric axis. And as they branch through, they actually divide different portions of the gland. So that's really problematic from our standpoint because it really doesn't give us a specific blood supply into the pancreas, which we can deliver potential therapeutics targets. Well, that was until about a couple of years ago. Kind of the last couple of decades, we really have, as interventionalists, really been exploiting our microcatheter-based development and our imaging technology such that we can now actually get into these really small arteries and actually isolate out the arterial blood supply of the pancreas. So that really is interesting because now it actually opens up an avenue where we can deliver therapy into the pancreas. So if we have the clinical machinery now to do this, what do we have on the basic science level that we can now start to optimize such that we can translate this into patients? So when we go back into looking at animal models, we actually find that the rodent pancreas is very similar to the human pancreas in terms of both its arterial blood supply and its gross overall morphology. So that then led us to think, well, okay, how do we get access to the rodent supply of the pancreas? Well, we've already said that the human supply was minuscule. So that kind of took our endovascular-based approaches in the rodent. So what we did is we tried to simulate this. So we developed over the last 2 years ways in which we can isolate the arterial blood supply in the rodent in a minimally invasive fashion. So what we do here is we actually isolate the blood supply to the pancreas by temporarily ligating off all the other branches that supply the rest of the organs. Then when we inject into the celiac axis, we can now redistribute all of that blood flow and hence the therapy directly into the pancreatic gland. And we can do this, we started in rats and we can now move into mice. So we can actually now do this in mice. And you can see there from the bottom couple of slides here, we can actually target not only the head, the tail, but even the entire pancreas while minimizing non-distribution delivery of any therapy. And the beauty now is that we can actually do this and recover the animals. And you can see there that the amylase and lipase, which are indices of pancreatic damage, remain pretty constant. So now we have a way in which we can actually access the arterial blood supply of the pancreas for therapeutic delivery. So then we said, okay, so we can now do that. What type of therapy would be interesting to give to the pancreas itself? So one of the cells that we're very interested in our lab is the mesenchymal stem cells. So these are an interesting type of cells because unlike other type of stem cells which naturally want to proliferate and subdifferentiate, these ones act like a mobile drug box. And what they do is they actually sense the local microenvironment and then they will release therapeutic regenerative factors depending on what they're sensing. So if they sense hypoxia, they will stimulate angiogenesis, or if they detect inflammation, they will secrete anti-inflammatory cytokines. So they act very interestingly depending on the microenvironment in which they actually are put into. And so the mesenchymal stem cells can be sourced from a variety of organs. The conventional one is bone marrow, but we're actually exploring not only the bone marrow, but also the adipose tissue-derived mesenchymal stem cells because they're more readily available. And also umbilical cord, which we're showing to be a little bit more potent in terms of their regenerative capacities compared to the adipose tissue and the bone marrow. And we look at their effect both in not only what they're secreting in a soluble form, but also within the exosomal forms. And this is interesting because the exosomal forms can then be used as cell-free therapies because they still contain the regenerative molecules that can modulate the microenvironments. And so these are what mesenchymal stem cells look like under confocal imaging, and we characterize their expression. And then on the right-hand side, we can kind of see how when you culture the mesenchymal stem cells with islets, not only do they actually improve their overall morphology and viability, but they actually also promote their function. And we've tested this while stressing the islets under various conditions. And we've shown that the adipose tissue, the adipose tissue-derived mesenchymal stem cells can actually coat the islets and protect them. So then we said, what if we actually now can give these mesenchymal stem cells into the arterial supply of the pancreas? So here what we did is we actually gave a drug which destroys the beta cells specifically in the pancreas. So that's STZ. And what we see is that once you give the mesenchymal stem cells intravenously, so a non-targeted approach, majority of them will get trapped in the lungs as their first pass effect. And so they actually don't basically protect the pancreas and allow it to regenerate. Whereas when we give it intra-arterially, we can see here that we can actually maintain normal glycemia within these animals. And the pancreas and actually the islets themselves not only maintain their morphology, but they also maintain their hierarchical structure. And you can see that there from the IHC stains that we've done. We then looked at where these mesenchymal stem cells are actually contained through, as I said, IHC, and we actually show that majority of them are actually within the pancreas and the spleen following the intra-arterial route rather than the other organs like the liver, liver, spleen, and the lungs. And now we're moving on to different molecular imaging approaches to prove that the intra-arterial approach really does result in mesenchymal stem cells or cellular therapies retaining within the pancreas and not being excluded through first-pass effects. So I know I'm short for time, so very quickly, technology. Is there a way to optimize this? So mesenchymal stem cells, the other thing we have to think about is once we give it into the arterial blood supply, they actually have to traverse the blood vessel, stick to the blood vessel, go through the endothelial cells, and then actually migrate towards the tissue, which is actually damaged. And so one very interesting technology which we're looking at is focused ultrasound. So we've all done this, when we're young, when we've focused heat waves into light into specific points to generate heat. And so now, clinically, we can actually do this. So we treat adult and pediatric patients with focused ultrasound where we actually focus sound waves to a specific point such that they can actually generate tissue ablation. But the interesting fact is that if we don't continuously focus these sound waves to raise the temperature of the tissue and actually intermittently pulse them, we can actually mitigate the temperature rises, but actually then focus on the mechanical effects of the sound waves. So what we're now seeing is that if we can actually start to kind of shake the tissue, we're interestingly finding that this can upregulate a lot of chemoattractants. And what we're now showing is that these chemoattractants are actually very important for not only stem cell migration, but also their activation. And so this is our setup, which we have in the lab, which we're actually focusing the sound waves on the pancreas and actually having a look at what happens to the pancreatic glands. And very quickly, we're seeing here that at the low intensities, when using the pulse mode, that we actually get no damage to the pancreas, which is important. But very interestingly, you can see there on the right-hand side here, we can actually modulate the microenvironment. So with low intensity sound waves, we're actually causing downregulation of a variety of factors. And when you actually increase the intensity, not so much that you're increasing temperature, but you're increasing the mechanical effect, we're actually upregulating a lot of the cytokines and expressions within the pancreas, which we're now seeing is actually going to assist in stem cell homing and activation. So with that, I'd like to end, and thank you very much for MCHRI for all their support in the Department of Radiology, and you guys can now go to lunch.
Avnesh, you did so well on time that there's actually a minute or two left for a question, if anyone has a question. This was stunning. Yeah, go ahead.
Yes, interesting talk. I wanted to ask, you mentioned exosomes as one option. So why was stem cells preferred instead of exosomes? Or if you
so we're looking at both. So one of the advantages of stem cells is, as the last speaker kind of alluded to, once the stem cells are in the local microenvironment, they are a continual source of exosome generation. So if we can get the cells into the actual microenvironment, they will modulate and be retained within that microenvironment and release continual amounts of exosomes. The interesting fact with exosomes is that once you have them, they actually aren't subjected to the GMP guidelines because they're cell-free products and they're smaller. So for endovascular delivery, there's far less chance of endovascular occlusion and clumping as well. So this also may be a viable cell-free therapy option as well. So we're looking at the different type of approaches, both cell and cell-free. Another interesting fact is that you can now determine the composition of the different type of regenerative factors within the exosomes depending on how you pre-stimulate the MSCs. And so what we're now finding is that if you pre-stimulate the MSCs with different inflammatory factors, we can actually titrate the exosome component that we're actually regenerating off.
And also, like in terms of immunogenicity, the exosomes.
Correct. Yes. Then there's but the MH, because the MSCs don't contain any MH class C2s, they are actually very immunoprivileged. But yeah, that's another very important point.
Thanks so much.